Good afternoon, everyone. My name is Susan Eshman-Levitan, and I'm the director of the MGH Stokel Center for Primary Care Innovation. And it is my great pleasure today to welcome you to our Senior Health Town Hall. We are so happy you could be with us today. I'm going to introduce all of our speakers, and they will then hand off the presentations to each other as we move through the agenda. And then once they're done, we'll come back and we'll take your questions. So our speaker today is Dr. Sari Sanchez, who is an infectious disease physician at Mass General in the MGH Infection Prevention, Hospital Epidemiology, and Antibiotic Stewardship Program. She will be followed by Dr. Don Berwick, who is President Emeritus and Senior Fellow at the Institute for Healthcare Improvement, which is an international improvement organization based here in Boston. And then we're going to hear from Dr. Sharon Levine, who is the section head of geriatric medicine in the Division of Geriatric Medicine and Palliative Care at Mass General. So with that, I am going to turn this over to Dr. Sanchez. Thank you.
Thank you for the introduction and for the invitation to be here. It's truly a pleasure. I'm going to give a little bit of a general overview to you all about, general statistics updated with regards to how this virus spreads, the diagnosis and testing, and try to get to the point of a lot of questions that have come up with how do we navigate social distancing with the need to see loved ones, and how do we do so in a safe way. And so just to start as a general overview, this is the COVID-19 virus, as you all know, was newly identified last December 2019. And since then, we've had more than 9 million cases around the world and around 2 million cases here in the United States. Here in Massachusetts, we've had a total of around 100,000 cases with greater than 7,000 deaths. And so here in Massachusetts, we've actually seen the community spread of this virus to start decreasing significantly since we experienced the peak in April. And so, I'd say that over the past few weeks with with reopenings, we're very eager to see, as long as we continue general safety measures, how this continues. Now, to give you all just a little bit of bread and butter information about how this virus spreads, we think that it mainly spreads through droplets from person to person, through respiratory droplets that are produced when an infected person coughs, sneezes, or talks. There's been a lot of different media coverage about this, and so I thought it was worth mentioning. These droplets, how we get infected is when these droplets that are in the air, usually they can only really travel around 6 feet, land in the mouths, or noses, or eyes of someone who is nearby, and that's how disease is spread. Now, if we also touch something that has the virus or shake hands with someone who has the virus, and then we touch our eyes, nose, or mouth without washing our hands first or using hand sanitizer, then we can also get disease. Now, the key thing that has been pretty changing for public health purposes is that we do know that COVID-19 can be spread by people who were infected and not showing symptoms. And so a lot of questions come up with regards to diagnosis and testing. Currently, there are still two main types of COVID-19 testing. Virus testing, which is usually known as PCR, and that detects whether or not you actively have disease or have the virus. And then antibody testing, which measures your immune response. Over the pandemic, testing capacities and who can qualify for testing has changed so much, and it has been a subject of so much confusion, because at the beginning we had very limited testing, and we're really only testing people who met a very, very specific criteria. And that's changed significantly over the past few months, even though testing is still limited. One of the main questions that we get often is should I be tested, or who should get tested for COVID-19? Right now, the main parameters that the Department of Public Health uses with regards to who should absolutely get a test is anyone who has any symptoms consistent with COVID-19, or anyone who's had close contact or has been exposed to someone who has tested positive for COVID-19. And usually these are people who are in very close contact within 6 feet for around 10 or 15 minutes when someone has been recently diagnosed. I think right now at Partners, testing criteria has been expanded from this. And I know this is something that everyone's very eager to ask is, can I come in to get tested? If I don't have symptoms, how can I be tested? So right now at Partners, in addition to those two criteria, we are really generally testing people who are coming into the hospital for procedures or having procedures as an outpatient, or people who are receiving immune suppressive treatment that either with cancer or other immunosuppressive conditions. Generally, those are the predominant categories of testing. At Partners, your doctor can order the test. We've allowed it per provider discretion. And so if you have any questions about testing or have any other indication that you feel might warrant testing, then you should really speak to your primary care doctor or doctor about this. Now, the thing that I would keep in mind is there's still a lot evolving when it comes to insurance coverage for what we call these gray areas that aren't people who are either symptomatic or exposed. So if you're symptomatic or you're exposed to COVID or have had close contact, your insurance will cover testing. I think it's a little bit more gray when it's another indication. And so that's something that I would keep in mind. The other thing that I wanted to convey is that we have testing, but we still don't fully know exactly what it tells us. I get a lot of questions about PCR testing. Our tests are pretty good at identifying at in that we trust the positive results, but we still can get negative results in people who we think might have disease, anywhere from 2 to 30% of cases. And so while testing is extremely helpful, it really shouldn't guide a lot of any other changes in behavior that we might make. For example, trusting a negative test to either meet up with someone or to inform activities. That's a little bit more of a gray area, and that's something that I did want to convey. After testing, a lot of questions that we get are when it comes to what treatments do we have available. And the two categories that I like to think of and that people often ask are vaccines and pharmacologic treatments, meaning medicines. Vaccines take a pretty long time to be developed. Right now, there are greater than 100 vaccines that are being studied as treatments for COVID, as preventive treatments for COVID-19. However, only 3 currently are in phase 3 trials, meaning large-scale trials to determine whether the vaccine might be effective. And we still don't really expect that these vaccines would be ready in anywhere less than a year. So there's still some time to vaccines. We've made some progress with treatments. There's still no FDA-approved treatment for COVID-19, but there are some emerging treatments, including steroids for hospitalized patients and antivirals that have shown promise. But the fact that we still don't have any FDA-approved treatments for COVID, and the fact that we expect a vaccine to take a really long time, or at least a year that we expect, is why we're going to come back to the issue of social distancing. And a lot of people asking how we're really going to come out of this. And the answer to that is that for us to really ever be able to assume our new normal, we really have to have a certain population a certain percentage of the population that's immune to this virus. Now, generally with other diseases such as chickenpox, people become immune. It's a really mild infection. People get infected. It's like when you get really close to someone that has chickenpox to get yourself infected. But we can't really do the same with COVID because of the severe disease that we know it can cause. And that's why the vaccines are going to be so important. But I've just said that the vaccines are going to take a really long time. And so that's where the mode of transmission of COVID is so important in informing how we know to stop the spread of disease. Because in the absence of treatments to prevent it or treatments to treat the disease effectively, how we can prevent it is through preventing the spread. And that's where the social distancing and the masking comes into place. When we know that this disease is spread with close contact. And so, keeping your distance from people or sort of socially isolating, we've known has been a really effective strategy, as we've seen over the news that cases have come down. We also know that because asymptomatic people can shed virus and spread disease, all of us need to be masked. And that's another very effective way to halt transmission, meaning to stop spreading the disease. But I think what we're finding as we evolve throughout this crisis is that we can't all stay at our homes forever. And that's where balancing physical health with mental health becomes all the more important. And a lot of questions that we've received over how to navigate this next phase of the pandemic, this longer term. And something that I just like to share is that, and something that I think is going to be really important for everyone to hear, is that it's not all or none when it comes to keeping yourself safe during this pandemic. Meaning that, because we decide to finally emerge from our shells and leave our homes and see others, seeing others can look like many different things that can have many different risks. And I think that's a little bit of what I'd like to talk to next. So first of all, I think that if you really, to keep ourselves safe in general, we should all be practicing general preventive measures, washing our hands regularly, again, because our hands are how we can bring our virus to our eyes, nose, and mouth. But importantly, also keeping your hands below your shoulders, because that's how, if you get in that habit, you can touch your eyes and mouth less often. Masking every time that we leave, a face covering or a mask, and then socially distancing. But as we try to think a little bit about socializing, I wanted to sort of break this down, as I mentioned, when it comes to risk. And so really the best way to prevent illness right now, as we've talked about, is to avoid being exposed to the virus. And that's really ideally, when you meet or gather with others virtually through Zoom or FaceTime. Now, if you decide, again, trying to balance out physical safety with mental and emotional health, that you want to see others, thinking a little bit about who you're seeing, where that happens, and what you do is important. So if you decide, for example, I think the lower risk end of the spectrum is to do smaller outdoor gatherings where you're able to keep a 6 feet distance from others, people wear masks, and you really don't share any food or other objects. That's pretty low risk, and that's an option that you can definitely explore. I think that if you decide to involve more people, that's where sort of the risk can go up. But if you're outside and not sharing things, and generally everyone is masked, it's generally as well a little bit of a lower risk. The risk generally goes up when you decide to either go indoors, which we know that ventilation can help reduce spread, or when you do larger in-person gatherings. And when you decide to not do socially distancing, meaning to remove your masks or to do a closer distance, less than 6 feet. Now, a term I wanted to sort of finalize by sharing a term that's been, that a few of us infectious disease specialists have been coining, called quarantine pods, meaning that if you feel like you really want to engage in more closer contact with a certain group of people, the lower risk way to do it is to establish what we call quarantine pods, meaning if you have family members, loved ones that you'd like to see more closely and not practice social distancing, meaning see them without a mask, the best way to do it is to establish a very small, closed group of people who are all otherwise practicing very strict social distancing from others, meaning they're not seeing other people closely, they're staying home, and they're being very careful. And choosing that group of people and having conversations about what everyone thinks would be safe and having conversations about what each person is generally doing in terms of grocery shopping, seeing others. But if you have that closed loop of people, a small group, that could be a way to reduce the risk of spreading disease or getting disease, but still be able to see loved ones. And so I think that, again, all of this requires a lot of thought. And a lot of, it's really a balancing act. But I think that, again, as we emerge into the more longer term phase of this pandemic, there are ways to be safe. And I think these are some of the things that I would think about that I would encourage my patients to think about as an infectious disease doctor. So I'll end there, and thank you so much for your time.
Okay, Dr. Berwick.
Thanks so much. Thanks, Sorry, for that amazing overview. I will be going into some rather trees compared to the forest you just covered. Thank you. It's a pleasure to spend this time with you. I'm very excited by this program and project. I hope I'll be invited back on other topics. What I've been asked to talk about is actually an intersection. I'm a Don Berwick. I'm a pediatrician by training, but my main career has been working on quality improvement of the quality of care all over the world through the Institute for Healthcare Improvement, IHI, which is a nonprofit organization that I co-founded many years ago. Now I'm senior fellow there. You all are welcome to go to ihi.org and you can join in that community. It's still a very vibrant global effort to improve care quality. Before anyone ever knew about COVID, IHI started a project with the John A. Hartford Foundation called AgeFriendly Healthcare. This was started about 3 years ago. It was the brainchild of the president of the John A. Hartford Foundation, Terry Fulmer, Dr. Terry Fulmer, who's a leading nurse in the nation. And she was concerned, as we all are, about the aging of our population and the demands this is making on healthcare systems to be helpful to people at this phase of our lives. The evidence is not encouraging. There's a lot about healthcare that is unfriendly to people who are aged, either well-aged or people who are chronically ill or frail elders, despite the excellent work of many geriatricians, such as one you're going to hear from after me. So Terry raised the question, could we develop a model of age-friendly healthcare? The concept was scientifically grounded because that very foundation, the John A. Hartford Foundation, had invested for 25 years in supporting researchers around the United States and in other countries on conditions in healthcare that help elders thrive. Very sound research by more than a dozen researchers, and that wasn't the only source of that science. But what Terry's idea was, pull together these scientists, a collective of about a dozen very distinguished scientists dealing with elder care, geriatrics, and ask them to pool their knowledge about what each had found out in their careers about the nature of healthcare that actually helps support thriving and compassion and engagement in care of elders. And it was called Age-Friendly Healthcare. It was remarkable. That was an incredible episode. I remember those scientists coming together, and frankly, scientists can be competitive with each other just like anyone else can, but that they put all the competition aside, they pooled their knowledge, and in a series of very interesting meetings and conferences, generated a model that became the framework for age-friendly healthcare. It's called the 4M model. No one believes this covers the whole terrain of knowledge about what makes healthcare age-friendly, but the 4Ms emerged as really powerful concepts. The 4Ms are these. The first and probably the prince of all of the M's is what matters to you. The concept is pretty clear. Before healthcare does something to a person, the most important thing to find out is what they care about, what their goals are, what matters to them in their lives. I often use a personal case myself. I was scheduled for actually a knee replacement that I never had to have, but no one ever asked me what really mattered to me, even though I absolutely knew what it was, which is to be able to cross-country ski. Being able to get out and cross-country skis is a central part of my recreational life in the winter. And no one ever asked me or offered information about that. That's just a small example. But when you broaden it and center healthcare on what matters, things get a lot better. A lot of what we do, we don't have to do. And a lot of stuff we would never think of doing, the family and the patient, the person bring to us. The second M was medication. Elders take a lot of medicines. The average is a very high number. I don't know exactly what it is lately, but it's often 5, 6, or 10 medicines that an elder can be on, even if they're relatively well, but certainly if they have a chronic illness. Well, these medications interact to behave differently in the elderly from the way they do in younger people. They change over time, and it's not clear that the communication systems allow people to maintain contact with what they should be doing with their medications. And so appropriate medication management was the second M. Lots of research on that. The third M was mentation. This has to do with a vulnerability that older people have, which is to become disoriented, to become delirious, or to lose track of things, especially in healthcare environments. Very rapidly, elders, even pretty well elders who end up in a hospital bed or an intensive care unit, they lose orientation fast. They also lose conditioning fast, by the way. The loss of muscle mass for an elder that's lying in a hospital bed is dramatically fast, more destructive in some cases than the disease they have. But mentation can be dealt with all the way from managing dementia, which is helping people who really have an organic problem around orientation, to people who are just situationally disoriented, as long as one attends to it. And so the third of the 4Ms was attend to mentation at all levels of disorientation, depression, delirium, and dementia. The last M was mobility. I already referred to the threat that elders have in healthcare, which is to become immobilized, which leads to all sorts of complications, pneumonias, loss of muscle mass, further disorientation. And there's a lot of research showing that in healthcare settings which emphasize physical activity and early mobility, people who fall into healthcare's arms do better. So those were the 4 M's. What matters, medication, mentation, and mobility. I have to say that COVID-19, as Sari was describing it, it echoes in every single one of that. It echoes in medication, because all sorts of pharmacology enters the picture in managing uh, uh, this disease. We don't have an antiviral yet that works, but there's plenty of medicines people end up with to help them through their distress during periods of COVID. And for elders, that produces certain vulnerabilities. Mentation matters. I mean, the social isolation that elders are feeling in long-term care, which is to some important degree necessary, it produces all sorts of toxic effects on the orientation and the ability of elders to feel in touch with the world, and it induces depression. Every epidemic brings with it a second epidemic. There's a disease that's epidemic, and then there's the behavioral health consequences of that disease. And in the case of elders, it's a real problem. And then mobility. We don't move around as much. We are trapped in our buildings because of the guidelines we need to follow in social distancing or physical distancing. That's a threat. So, and then of course, what matters? I'll do a little editorial here. I had a disturbing conversation, which you may want to talk with me about during Q&A, with a doctor at a cancer center for children. This takes care of children. This person is not in care of elders, but children in very extreme conditions of illness. And that cancer center had decided to insert a rule, which was every child could have only 1 visitor through their stay. And this was producing tremendous distress in children, families, parents. And this doctor was quite angry and said, "Oh, aren't we doing something wrong here? Safety matters, but other things matter too. What would happen if we were to ask the patients and families the rules they would like? They're as smart as we are, and they could figure this out." And I think that's exactly right. Healthcare, when it's correct, is co-designed with people. It's not that the smart doctors invent the rules and then patients carry them out. That's old thinking. The right way to care for anyone, a child with cancer or an elder who's just finds themselves with a chronic illness, is to focus on what really matters to them. And I think we get smarter and better care there. And it's true in COVID. We better be designing. We're going to be living with COVID, unfortunately, for a long time, I fear. And we better be designing the social systems, community systems, and the healthcare systems that really are what people want and need on their terms, not our terms. And that's going to be a challenge. So the results have been great. I have never seen an outpouring of interest like I've seen to this 4M project, the AgeFriendly project. We began with a prototype of about 4 large organizations, Kaiser Permanente, Providence Health, Anne Arundel, and Trinity Health, and they were kind of the prototypers. They worked with the scientists and tried stuff out, refined ideas, and it was really exciting. And then we opened the door and said, "Who wants to play?" 100 organizations signed up immediately, and so this went from 4 to 100 in months. We're now, I think, over 700 healthcare organizations in this country alone that say we want to be age friendly. We're seeing at Yale New Haven Hospital, they've put this is a question they now ask if you show up there and you're in the aged group. What's the one thing about your healthcare you most want to focus on so that you can do fill in the blank more often and more easily? That would have been my knee if they'd asked me that question. I want to be able to ski. Nobody ever asked me that question. Now they would at Yale, because they're focusing on what matters. Medication reconciliation and work is going on every place. Anne Arundel now has, they've actually increased their patient satisfaction scores dramatically by having a pharmacist do systematic medication reviews and making adjustments for every single person over 65 at the point of discharge and in follow-up. On mentation, we're seeing lots of work going on to early detection of depression, early intervention on disorientation and delirium. Hartford Hospital is seeing a dramatic decrease in the length of stay for patients with delirium as a result of their work on keeping patients oriented. And mobility, here's an interesting observation from one of the members, again, Anne Arundel Medical Center in Maryland. They used to celebrate moving a patient from the bed to a chair. That was mobility. And then they kind of had a sudden awakening. They said, that's not mobility. That's going from a bed to a chair. And so they changed the whole goal set for getting people up and around, in which they've loosened a lot of restrictions. For example, people now leave their hospital room to go get their meals. In the COVID era, there's probably a little more restriction than that. They have a group exercise class for elder adults right in the hospital. Some of this will be impeded by the restrictions that Sari told us about, but in the longer run, they're taking mobility completely differently. So it's pretty exciting. It's gone global. There are 4M age-friendly work going on now in multiple European countries and with the same kind of interest. So it's pretty exciting. It's hard to find a silver lining in the COVID world, but focusing on the needs of elders and really designing around them is one of the stories that we'll be able to tell when this is all over. Thanks so much, Susan.
Thank you. Dr. Levine?
Thank you, Dawn. That was a wonderful, wonderful lead-in to narrow it down a little bit. So I'm Sharon Levine, and I'm delighted to be able to tell you a lot about things that are going on in geriatrics at MGH. We are a fully engaged participant in the age-friendly health system here at MGH and are making sure that we are introducing the 4Ms throughout the hospital. If you ever wanted to know what a geriatrician does, finally somebody came up with how we describe what we do. Because what geriatricians do is address all of this, and no one could come up with a succinct way of saying it until the 4Ms came here. And that's why gathering a bunch of geriatricians in a room and coming up with this was absolutely fantastic for all of us, because that's what it was. And it actually was 5 M's originally, because multimorbidity, meaning people that have a lot of medical problems, was the 5th one, but it's easier to measure the other 4. So I think we can, there are only 6,700 geriatricians in the United States who are board certified. That is an alarmingly few number of geriatricians. But that means that we have to be able to help systems and other docs and providers and all the specialties that work in systems learn what we do and be able to apply those principles. And that's what AgeFriendly does. Prior to COVID, we got started in the winter with a truly interprofessional and interdisciplinary advisory committee here at MGH. We had nurses, physical therapists, occupational therapists, pharmacists, social workers, physicians in different specialties, and people practicing in the hospital, people practicing in clinics, people practicing at home, and got lots of engagement. And we started, as Don said, you can start little. You just have to start with a little, idea and see if you can make a change. And if you can make that change just by asking the question, and I totally agree with Dr. Berwick that what matters most to people is one of the most important things. It's the framework in which everything else fits. So one of the things we are doing is there's a memory care initiative that was started recently, earlier this year, which is a team, a doctor, nurse practitioner, social worker team that's embedded in the primary care practices here in one of the primary care practice here as a start, to help internists and generalists help take care of patients that have dementia, memory problems. And it is fantastic because it really covers all the 4 M's, starting with what matters to you. Even if you have memory, even if you have memory impairment, what's important to you and your family, and caregivers, I would add to that. Looking at medications, which can make your memory get worse just from the medications themselves. And then the mind or mentation is, of course, the definition of people that have dementia, but people with dementia are more predisposed to having things like acute confusion or delirium, as Dr. Berwick was saying, but also depression because of awareness of changes and inabilities. And then finally, mobility is very, very important for people who are older adults who have functional impairments and are stuck in the house, even if they have dementia, to be able to get out and get exercise like everybody else. So we are embedded in primary care, and we are really taking this very seriously, at this co-management, and looking forward to small changes, incremental changes, but that really make people's lives better who are co-managed with their primary care doctors. Another thing we're doing is we're having serious illness conversations with people here. And that also deals with what matters most to you. What are the things in life that are important to you? And what are your worries? What are your hopes? You want to go cross-country skiing? That's important to let us know. And in what kind of a life do you want to live? And in what situations might you not want to have things done to you that we might be doing, especially in the time of COVID? So in senior health, we have had scores of these conversations, these serious illness conversations with our patients, starting even before COVID. I do these routinely every day that I'm seeing patients. I'm having these conversations and reiterating them actually in the time of COVID, but we did thousands during the COVID epidemic, all over the hospital in every department. Another thing, so we're continuing to do that, and that really contains what matters most. That's at the core of a serious illness conversation. And then in the emergency room, because a lot of patients either come into the emergency room confused because they're ill, or they become disoriented in the emergency room, we are looking at how we can best screen for confusion in the emergency room so that we can give them our delirium cart, which has all kinds of things that people can do to concentrate and focus at a time when there's a lot of dinging bells and there's lights going on and alarms and all of that. Delirium was a very big problem during COVID because of the reasons that Dr. Berg was talking about in terms of restrictions on visitors, especially for patients with memory impairment, but also, sleep-wake, cycle disturbances, and people covered from head to toe, and all of that, and inability to be in touch with people that they know and love. So we are really excited about doing Age-Friendly here at Mass General, and are working with lots of folks who are very anxious to bring this to their floors. We have many of the floors where some of these things were going on were converted to COVID floors during the surge, and they're all reverting back to their previous lives as ambulation nation, where people are focusing on getting people out of bed to do the kinds of things that Dr. Berwick was talking about, or ones that were focusing on making sure people didn't develop delirium while they were in the hospital, and if they did, because it's usually a sign of something else, to help them to address those issues, because delirium is a sign of something else that's going on that has to be identified and then addressed. I'll take a little turn now to talk about senior health and what we're doing. So we are here for you. We have been here for you. We've been here the whole time we've been open for business. We've been taking calls, we've been calling you, and we've been doing virtual visits for a lot of the time. Most of our visits were virtual visits. And I have to tell you, I have, as a home care doctor and who has spent most of my life in people's homes doing house calls on frail homebound elders, I felt like I was back home because I could do almost everything on an exam, especially if there was a family member who could help me do part of my exam, like push away, get up from a chair, put your finger in the leg so I can see if there's any swelling in the leg. Help me with this neurologic examination. And then I could still say, open your mouth and say, show me your rat. So we could do so much of that. We could see who the people who are important in your lives are. We could look at your meds, and we could see you in your environment. I saw wonderful things. People took their computers and said, look at the view I have out my window. So they really loved that. But even so, we now have patients coming in, and it's important. About 15% of our patients are coming in, and we are open for visits, and we have been. If somebody needed an injection in a swollen joint before they had it replaced, then we could do that. We could look at things that we just couldn't do in virtual, as a virtual examination. So when you come to senior health, and those of you who get your care elsewhere, I will tell you, these are the rules that apply throughout the entire Mass General, all the clinics and everywhere. This is infectious disease 101 that's happening everywhere. So we've set things up so that when you come in, you are met by somebody who will ask the usual questions that that were talked about by Dr. Sanchez in the beginning. Do you have any sniffles? Do you have a cough? Have you had a fever? Are you short of breath? Your temperature will be taken. You'll be given a mask. And then we're actually taking patients right back to the rooms. The rooms are sanitized before and after every patient, and I mean sanitized. Everybody has masks on, and we are, the furniture is cleaned, everything is clean, the keyboards are cleaned, and people are brought back. I will say that we realize that many of you have caregivers who come with you to appointments, and we're trying as hard as we can to avoid too many people in a room. So if people are able to be seen without 2 people in the room, we're trying to do that. But if someone has memory impairment and really needs somebody there, we're accommodating that. Speaking of caregivers, I think it's very important for those of you who are caregivers to make sure you have a backup plan in case something happens to you. I'm not talking about COVID, but I'm talking about you fall down and get hurt and you're not around. So it's really important to have a plan for what you'd like to do and identify somebody in the case that you are incapacitated in some way. So just to bring it back around, the 4 M's is at the center of everything we do, even here at Senior Health, and what geriatricians do in general, and what now institutions, with the help of the Institute for Healthcare Improvement and the John Hartford Foundation, are trying to do nationally and internationally. But right here in our world, we're here for you. And whether you're part of Senior Health or you're not, everybody is following the kinds of rules and distancing rules that Dr. Sanchez talked about, so we can really provide you the best care that you need, because we don't want people not to come in. It's very hard sometimes to tell people you got to come in. It's really important. We need to see you. Don't sit there at home. I just heard a piece on the news that people were sitting home with heart attacks and stuff. That's not that. You don't have to be afraid to come to the hospital and see us. We're ready for you. So we miss you. We want to see you. We're looking forward to catching up with you again. And we're also hoping that you are cohorting and practicing the rules that we've talked about. And we are going to apply all the rules of the 4 M's when you come into our practice. So I'm going to pass the baton back to Susan Edgman-Levitan to take your questions.
All right, thank you very much. Thanks to all of our presenters. These were wonderful presentations and so informative. So before I go to the questions that have come in through the chat room, I just wanted to answer very quickly a question that we got from one of you that was emailed to us before the session today. And the question really asked about how Partners has a biobank that at this point has about 90,000 enrollees. And we also are participating in a very, very large study funded by the National Institutes of Health to create the largest national biobank actually in the world. And one of the goals of the national biobank, which is called All of Us, is that 50% of the participants will come from communities and populations of people that have traditionally not been really involved in clinical research. And just to be very candid, that basically most of the people that are involved in clinical research are white men. And so the participants in the biobank and the kinds of people that we're trying to recruit into that include older people, people from diverse ethnic backgrounds, children, people that live in different environments, have different occupations, etc. So the question we got is, how are we using these resources with respect to the COVID pandemic? So just a couple of facts. We have over 8,000 internal biobank subjects that were tested for COVID, and out of those, 2,000 were COVID positive. The Partners Biobank has over 30 requests from researchers to access samples for various COVID-related research studies, which is one of the reasons why the biobank was actually created. And we also are supporting 2 networks of investigators examining the immunology and the genetics that may impact COVID and how people respond. And then we also have supported several NIH grants using the internal biobank for COVID research. So if you are not a participant in either of these studies, you can contact Senior Health. And if you are enrolled in Patient Gateway, you can also get information there about how to enroll. So I want to go to, we got several questions that I think I'm going to ask Dr. Sanchez to answer. A lot about the quarantining that you discussed. So I think one of the first ones, and this is something that I've thought a lot about, can a frontline healthcare worker or somebody in an essential worker capacity be part of a quarantine pod? And then I think there's, so go ahead with that.
So first of all, I think I've already started to look at these questions. They're amazing. And I think what I want to say though, as I answer them, are 2 things. The caveats being that, generally in medicine, when we talk about risks, we usually rely on data from things like randomized clinical trials, or sort of knowing that there's evidence that can sort of support the quantifying a risk and saying that it's 1%, 20%, either that be of mortality or of getting a disease. Now, we don't have that data. This is a disease that we're learning about day by day. But what we are using, and sort of what I will use to help guide, is knowledge about what we think is the mode of transmission of the disease and sort of how we think it's spread. And I just want to be sort of clear, because it is hard to assign a number. And that's a little bit of why you'll sort of see me talking in gradations, meaning lower risk, higher risk, based on that knowledge. And it's because we're still learning a lot. And the other thing that I wanted to say before I answer these questions, and I just love Dr. Berwick's the M's, is that a lot of the answers are also going to really depend on what matters most to you. Because I think that for many people, it might matter most to really, really reduce your risk or sort of present it to none by staying at home. And to others, it might matter more to be engaged in these activities. And so I think that's part of the spectrum of things that I think is important to consider. And so I'll start with the first question with can a frontline worker be a part of a quarantine pod? And I think that's where the what matters most question is really helpful. So a frontline worker, I think that the answer to this is yes, they can be. I think that what's important to know is that because they are not staying at home, they are having contact with others. And so their risk of acquiring COVID is not zero, meaning they're not able to stay at home and minimize their exposure to the disease. And so I think that but needless to say, if you have a daughter or a loved one, a sibling, et cetera, that you have to see, that's where what matters most piece is important, because they can be a part of your quarantine pod. I think it's just a matter of knowing that their risk of getting the disease is going to be higher, meaning that your risk of getting the disease is going to be higher. And that, depending on what kind of frontline worker they are, talking about the kind of measures that they should be taking, and just conversations about things that the group would like to know if they think they've been exposed. Obviously, if they develop symptoms, they need to inform everyone. But I think it's just all about having those conversations with that person. But, for example, in healthcare, we really do, I'm of the school, at least personally, that the personal protective equipment can work. And we've seen in some other studies that healthcare workers have not had as significant rates of infection as others, but many frontline workers, it can be different. So that's what I would say, is they can, but it's a conversation. I'll see, there was another question after that from Madeline about what is the risk of visiting outside with COVID-19 recovered elder who lives in a residence where multiple residents died from coronavirus. It's a great question. So I think there are two important things there. COVID-19 recovered, we don't yet know how long this immunity is going to last. And we presume that you're going to have immunity just based on what we know from other viruses, but this is not sort of something that we know for sure. And so I think that the risk in visiting outside can be low if you visit outside, maintain a distance from others, and maintain your mask on. That's something that I think if you practice that, you can dramatically reduce the risk and safely visit. That being said, the recovered piece, I wouldn't bank too much on that depending on how much time has passed, because that might change. I can keep taking questions on.
Can you answer the question about the person who wants to go to Martha's Vineyard with her friends?
Oh, sorry, I hadn't gotten to that question yet.
Yeah, can you make a recommendation about 80-something friends, each living independently, spending a week in late July in a cottage at Martha's Vineyard? And then I think there's a second part where about driving and cooking together and that sort of thing.
So again, the word recommend, it's hard. I think the best that we can offer is guidance. I think that the word recommendation, it's hard to, because again, we're learning so much. I think that what I can say is this sounds like a great activity to pursue and that can be done safely. I think the key thing to note are going to be the preparations for before. So if you're going to have a group, I think you need to have conversations about the 2 weeks leading up to the trip, that everyone is everyone staying home, maintaining a social distance and being safe. I think that's going to be super important because you really want to minimize everyone's risk of actually being exposed to COVID-19 before the trip. And we know that people can shed virus or can become sick within the 14-day window. So 2 weeks before the trip, make sure that everyone's on the same page about that, about maintaining social distance, staying at home and being safe. You can call I think people are really looking into the different types of arrangements, like, calling if someone's going to be renting a house or et cetera, to figure out if people have been occupying the house beforehand, cleaning protocols, that kind of thing. So I think that would be, I think, my main piece of advice. I think that, there was a second part of the question with regards to wearing masks in the car. Again, there's no real way to know what the risk is of each of these activities. If you're in a car with someone, I'd say you should at least roll down the windows and increase ventilation. That'll be the best way to minimize your risk of getting disease. Obviously wearing a mask too. And in general, again, wearing masks and maintaining your distance from others really will be the best way of minimizing your risk of getting sick before the trip. And, if you've all taken these measures before the trip, then you can think about doing, that'll be like a form of a quarantine pod, whereby then you can all sort of be together, we can decide whether you want to be together without practicing social distancing in the trip, because you've all taken measures beforehand to be as safe as possible. Always recognizing that the risk isn't zero, but it's probably going to be very low.
Okay, I'm going to give the next question to Dr. Levine, and it's a question about the vaccine development and how an article in the New York Times talked about the vaccine testing is not using a statistically significant number of seniors. And so there's concern about how effective might it be. I think this is, again, one of the reasons why the biobank work is so important. But it's also, will there be a priority about less distribution in older people as well? So Dr. Levine, do you want to take that one?
Well, I think Dr. Sanchez may be able to answer the medical issues, but I think that there's so much uncertainty. I think that we don't know. What we do know is that older adults are at the highest risk of dying of COVID by a lot. especially the ones that are in nursing homes. And so, the question is, who's involved in these vaccine trials? Does it involve our patients? That's where maybe Dr. Sanchez can answer some of these things. I think, what was the first part of the question?
About there weren't many older people involved in the trials.
So I think that's a very important part of information that we would need to know, and it's part of the ageism. I will just say about the inclusion of older adults in studies in general. I mean, it's getting better, but there are many studies that don't include adults, and so even though we have proof in people at younger ages, it may not bear out for people who are older, and that's one of the real issues. And also, just to really sort of make a disparities comment, is that ageism is very rampant in this country, and those of us who are geriatricians know that. And so I would say to the people who are developing these things to make sure that people who are older, and especially over the age of 80, are involved in any kind of trial, not just for infectious disease and vaccines, but for cardiovascular disease, for strokes, for all this stuff. It took a long time to get there. And there, people who are in nursing facilities, some of them may be there not for reasons that they don't have their cognition or whatever. It may be because they have nobody to take care of them at home, and that's why they're there. And why should they be excluded from these trials? So I want to pass it back to Dr. Sanchez to maybe comment more particularly about vaccines. But I do think we have to keep in mind that ageism is alive and well.
And also, Dr. Sanchez, just to add on to that question, can you just say a couple of words, because we've gotten questions about, are we doing antibody testing at Mass General?
So with the vaccines, I mean, I'm not unfortunately as familiar with vaccine clinical trial protocols. I do know, and I think it's an important issue to be raised. We've seen so many different kinds of disparities play out with this epidemic when it comes to our elderly population, our minority populations, very vulnerable populations. And so I do think it's important. We do know that with the influenza vaccine, we have a vaccine with higher immunogenicity for elderly populations because we know that the others sometimes aren't as effective. So I'm not sure what the answer to that question is, but I do agree it definitely is an issue that warrants attention. With the antibody testing is available at MGH. You can certainly, again, all the testing is being prioritized based on indication, but you can talk to your primary doctor about ordering it. I think that the key thing I would say about it is that it might not necessarily be covered by insurance, and I do know that some patients have had to pay out of pocket for it anywhere. I think I've heard around the sum of $100+ dollars. So I think, certainly you would have to consider if you are willing to pay out of pocket for it. And, I think that the type of information that it will give you, I don't know is necessarily going to be as helpful, because it will, I think that it might tell you, if you do have a positive result, it might be indicative that you had a prior infection, but we still do not feel comfortable relying on antibody testing as a marker of immunity. So if you had a positive test for antibodies, your doctor would still not recommend that you use that to just sort of go out and about and, that you're safe from getting re-exposed. And so I think in light of that, I'm not sure I would necessarily recommend getting it, but it is available.
Thank you. Thank you. So I guess I have one last question, and then we're probably going to have to wrap up, but it's a question about, can you say a little bit about the risk for people who live in retirement communities as opposed to nursing homes or assisted living? And I'm assuming that by retirement community, we're talking about places that have independent living, assisted living, and also a nursing home component. So Dr. Levine or Dr.
I
Sanchez.
think this has been one of the hardest things for older adults, because people move into these places because they want to have the ability to be socialized and to have congregate meals and to do all of the things that you do, or if they have a family member who has dementia who can go to a dementia day program, and all of those things have ceased in these environments. The places that I think what they've done is really try hard to have PPE and to limit visitors because they're trying to keep an entire place as a cohort and within a quarantine. And the more people that come in and out, the harder that is. So I understand it. A lot of my patients, when they knew that this was coming, went and stayed with their kids if they had them close by, because they knew they wouldn't be able to see them. Because it's really, it's really hard not to see your kids. It's like you're just dying inside. Yeah. Zoom is great. You can have dinner once a week, but it's not the same thing as a hug. And so I think what buildings are doing is right. And I don't think it's good to hide it when there are incidents in these buildings, because I think it's important for people to know, just like you would want to know if somebody's a first responder, because this is all about you're willing to take risk and uncertainty. Here you're dealing with an industry that runs this building, and what kind of risk they're willing to take. They're willing to take in their buildings, and they're trying to contain things. But these are really hard questions. I think things are loosening up. I have patients that now have visiting outside. They can go out. It's a little bit better, in some of the places, leaving it at the food at the door, like you're in jail, has changed a little bit. But I don't know if Dr. Sanchez wants to take about this, but thank God you didn't ask about nursing homes, because that is a whole other topic. These places are a different story.
Yeah, I think what I'll add on to what Dr. Levine said is, I think that the congregate nature of just sharing, being around close to others, sharing different kinds of, not necessarily utensils, but like other things that go from room to room, that's where you see, and really not being able to maintain that close distance, that distance is what makes for higher risk. I think that the one thing that I would say is, when thinking now about risk, is I think I would approach it in terms of trying to figure out what measures each facility is taking with regards to things like universal masking, employees being screened for symptoms, and sort of policies around masking, around, leave of employees if they're sick. And what are sort of policies with regards to visitation? Is it happening outside? I think that really I would sort of think about it from that standpoint, and how trying to figure out how the facility is moving forward and the measures that they are taking to keep everyone safe. And similarly, as Dr. Levine mentioned, it's not perfect, but I think that the transparency of a facility in disclosing what is happening, I think, is also a sign really important, because I think building that trust is paramount right now more than ever.
Yeah.
So that's, yeah.
Thank you. That was a great answer. And I agree. It is so mentally helpful to have your children, where you can see them and hug them. So we need to end now and wrap up this wonderful discussion. A few last things to make sure everyone knows about. We will send out the recording of today's presentation to everyone, and we also include some materials with the recording. We have a resource document about community resources that might be helpful to you. We have information about what to expect in the event that you might need to come into the hospital, and information about identifying a medical decision maker, how to talk to that person about what matters most to you. We also have some healthy cooking recipes, and we have an exercise program that you can actually sign up with and do as a Zoom exercise program that's really fun, that's offered twice a week. I also want to make sure that everyone knows that on July 21st, and we'll be telling you about this again, the MGH Dementia Care Collaborative is going to be hosting a conversation with caregivers at 5:30 p.m. And the topic is going to be Choosing Joy with author Helene Berger. And it's an excellent book about the life of a caregiver who took care of her husband with Alzheimer's. So we really encourage everyone to join us for that. The information is available on the MGH Dementia Care Collaborative website, and all the recordings for all of our town halls, and we've had several, are also available on the MGH Geriatrics website. So with that, I'm going to thank our wonderful speakers. Thank all of you for joining us today, and I hope you have a wonderful rest of your day. Take care. Bye-bye.